Good afternoon, I'm Peter Hinerangi. We have two other PHONZ members here, Patrick and Barry. I'm going to start us off with a karakia. I'm going to formally welcome you and then introduce our speaker, Dr. Rawiri Jansen. And I'll translate this as I go. Kia hora te marino, kia papa pounamu te moana, hei huara I mā tātou I tēnei rā. Aroa hatu, aroa mai, tātou I tātou. Let the calm be widespread, let the sea be like pounamu for us, a pathway today. Be kind and respectful to each other. Kei aku nui, kei aku roa, ngā mihi kia koutou kua tōmai ki tēnei hui o tātou, o te rōpū mātai hauora paupuri o Aotearoa. No mai, haere mai. Te hau kainga Ngāti Tōrangatira te Aotearoa, tēnā koutou, a rātou mā kua wehi atu moi mai rā koutou I tō moinga roa. Rātou kia rātou, tātou kia tātou, tēnā koutou. To our many distinguished guests from here and also from overseas, welcome to this meeting of the Public Health Observatory of New Zealand. I acknowledge the local iwi, Te Ataarangi and Ngāti Tōrangatira, and I pay my respects to those that have passed. My name is Peter Hinerangi. I'm a member of the steering group of PHONZ, and I'd like to welcome you here. Our speaker today is Dr. Rawiri Jansen. Ngā mihi kia koe Rawiri, ngā mihi kia koe mā tau tautoko, mā tau mahi mō ngā iwi katoa te motu, ngā mihi anō o kia koe mā tau tauko o manu te haora. Tēnā koe Rawiri, nau mai, haere mai, ki wainganui o tātou. Over to you, Rawiri.
Kia ora, thank you. Sorry, got phones going off. I'm in clinic today. So, ko taku mihi anō kia koutou, ka mihi tuatahi atu kia koe Peter, nau I tūwhera tā tātou hui. Tēnei au e tautoko nei ngā mihi ki te mana whenua. Ko nei au I raunga iti, tētahi marae I waho o Waharoa, tēnei au e mahi nei hei rata hāpori. He uria hau nōko nei, no Ngāti Hinerangi me Ngāti Raukawa. So I'm sitting in my clinic. Raunga iti marae is a small marae-based clinic. It's nurse-led actually, I've got to tell you a bit of details about it, because I'm busy trying to decolonise the health system in Matamata. And so you probably ought to understand a little bit of the history of Matamata. So we've got a lot of land that was, confiscated. My own iwi, Ngāti Hinerangi, we had our treaty settlement read in Parliament in the last couple of years, and the Crown apologised for attempting to exterminate Ngāti Hinerangi. So there's a kind of complex, deep, painful history. And then on top of that, we've got, all this farming settlement stuff, and then we've got health systems that have been set up which have for a long time excluded us. And so this is a way of trying to build a capacity and support a community really that wants to be part of meeting its own health needs. And so over a couple of years now, it's sort of grown. We've got a really good base clinic, open 5 days a week. Okay, I'll tell the truth, it's open 5.5 days a week, because there's lots of whānau who are working who can't get in during the week. And so Saturday morning becomes quite an important exchange for quite a lot of our working whānau. But we've also got a Kaupapa Māori mental health program. And then we've got sort of big aspirations for other things to happen. But so, as I say, I'm sitting in clinic today. I could unblur my background and you'll see that it's a modest building. and we've got big aspirations, but we've got something started, and it's it involves me being a telehealth GP as required, but turning up as many Fridays as I can get here. So I love it because it's where I'm from. Anyway, I've got a presentation for you, Peter, and then we can have an interrogation and a conversation. So I'm going to share my screen. Oh no, I have to do this properly. Okay, hold on. And sorry for being late. I'd agreed to do this for Rihanna, and did everything like, yep, okay, I've got some material ready to talk to, but the one thing I didn't do is put the Zoom details into the chat function. So my bad there. And now I'm going to share. I've got this ready. Right, and you give me a thumbs up, Peter, you can see it. Beautiful. So this stuff will be really familiar to you all. I think many of you will have read diligently the legislation and then the interim New Zealand health plan, which is great. And then I've got a parable, and I've just been using it, and I'll get to that as soon as I can. Okay, so now in yellow it says old, so I haven't formally said, is it okay if I share this stuff? But what I'm going to share, I'm going to talk to some of the principled stuff rather than the detail. And by the time this formally gets released, it may be quite a bit different in terms of the detail. But if I just jump to some of the points here, so there's just way too many words on here to go through it all, and that's not my intention. But in the middle section, in the middle of the middle section, it says equitable funding. And so you would expect and you'd recognise that Te Aka Whai Ora is going to be relentlessly focused on equity. And one of the things that the Y2575 Tribunal report did was, well, of course, it recommended that we should have an independent Māori Health Authority. So boom shakalaka, here we are, we've got one. And it also made some other recommendations, and one of them was around equitable funding and to review the capitation funding. And so what does equitable funding mean? And that will depend on lots of complex factors, but it's a really important conversation. It's a really important place for Te Aka Whai Ora to be influential. So staying in that middle zone there, you can see that we're interested in increasing Māori presence across the system. In my own words, I would describe that slightly differently. I would say we're interested in having influence out of all proportion to our size. So that means that Te Aka Whai Ora will want to be engaged with, working with, in partnership with other parts of the health system, intentionally trying to be as influential as possible. And the influence that we're looking for will be directed towards equity. So we want, in this particular part of the program work I'm showing you, we want to see more Māori leadership. We want to see more Māori in all parts of the health workforce and all of the professions. We want to work with hauora providers to ensure that they've got training programs and access to building workforce. And again, that will track into funding. And we're naming that we want to work with the iwi Māori partnership boards. And so naming that is, just to be really clear, Te Aka Whai Ora is a Crown entity. We're an independent statutory entity, but we're Crown. And so the iwi relationship has to be deliberately, in a determined way, we have to work with iwi partners. Above that, I've got that we've got the focus on prevention and health promotion. Jump to the left on the column on the left of this. I was hoping that we might re-language that to include the R word. And at the moment it talks about ethnic inequities, and it talks about the health system performs worse for Māori. I think we could name it and say racism. And we're really interested in being counter-racist, being anti-racist, addressing that. The strategic levers down there are not going to change. Those are kind of bedded in now. So we talk about enabling mana motuhake, we talk about indigenising the health system, accountability for health outcomes, enabling collective impact, and ensuring equitable resourcing. Now this slide has got the big structures. So you can see Te Whatu Ora. Te Whatu Ora is really fucking big, right? It's 86,000 employees. It's the largest employer in the country. It's as big as Coca-Cola is, worldwide. It's big. So I haven't described that in this diagram, but let's just notice there's Te Whatu Ora, there's Te Aka Whai Ora. It's nicely in the centre of the picture. There's daylight between it and Te Whatu Ora. There should be daylight between Te Aka Whai Ora and the iwi Māori partnership boards. And we also notice Ministry of Health and Public Health Agency on that side. And in talking to this, I'd say, notice that Te Aka Whai Ora has some special powers, or also known as superpowers. And that includes monitoring other parts of the system. So we've got a specific legislative power, and but we're definitely in as a Crown agency. All right, so that's, I can stop sharing now. I want to tell you my parable. Oh, any questions so far? I can't see any questions at all, because this is one of those webinars where I can only see the panelists, and if people are sitting there having their cup of tea, I can't see them.
Patrick, we have our visitors, everybody that's here, there is a one way to get questions to David is to click on the bottom of your screen. There's the Q&A. So if you click on that, if you have some questions, you can write them in there. And I also think, Patrick, you correct me if I'm wrong, but people can still put up their hands. Is that still the case, Patrick?
That's right. So at the bottom of your screens, participants, you should see a button that says raise hand. If you click that, we, the hosts, get a notification, and then we can unmute you and you can ask your question the old-fashioned way.
All right, so now tell my parable, and I've opened up the attendees. I can see 73 people, many of whom I know, and many of you know me, so that's deadly. So my parable is about partnership. And the parable goes like this, Peter. Imagine two people get married, and it could be two men, and it could be two women. Fuck, it could be one man and one woman. Doesn't matter. It's two people get married. And those two people are in partnership. And so they make all the big decisions together, right? As a partnership, it's 50-50 there. They're going to make decisions about moving town, getting a new job, or buying a house. Okay, yeah, buying a house. So they agree to buy a house, and they agree to get a mortgage. Now, that's a big decision. And those big decisions are made 50-50. And having made the decision, you don't resource that mortgage 50-50. One of the partners is earning 80 and the other one's earning 20. So resourcing the mortgage, which they agreed 50-50, is actually resourced probably 80-20. If you don't do that, the person who's earning 80 says, no, we'll resource it 50-50. Then that constrains the decision about what kind of house you're buying and what the mortgage is, because the person with 20 goes, well, shoot, I got to go all in to maximize. So don't do that. So we go, yep, the big decisions are 50-50, but the resourcing of those big decisions has to be done equitably. So it's 80-20 or whatever. And so the truth is that Te Aka Whai Ora is less than 5 to the Whatu Ora 95. So you imagine that we agree some big decisions, we got to figure out how to resource those things. Actually, to be honest, our 5 is supposed to be really principally directed towards things that are sort of kaupapa Māori services. If we're commissioning services, we're doing kaupapa Māori services. And you know what? I don't think I need Te Whatu Ora's opinion on our kaupapa Māori services. Just to be clear, leave that bit alone. So there'll be some things we work together, and in general, I think there might be some big decisions we make, and we go, okay, let's make sure that we've got skin in the game. Te Aka Whai Ora would like to put in $1 million. If we put in $1 million, how much does Te Whatu Ora put in?
95 million.
Well, I really enjoy your maths. I'm loving your maths. But you know, if it was 5 to 95, then they'd be putting in 19 or 20 million. But it's, you know, that's a big differential in terms of how we resource some of those things. So the partnership is 50-50. The resourcing of some of those decisions won't be 50-50. It might be closer to, you know, 80-20 or 5-95. And then there'll be other things too that we need to figure out. So the, you know, the tikanga of how we raise the kids together might be influenced in a different way. So, and by that, what I'm trying to indicate is that you've got, I don't know, legislation or regulatory, you know, there's other functions, and that they might not fit into this really simplified parable that I've given you. But what I'm trying to do is indicate that we've got a small bucket of money, but we want to influence the big bucket of money. All right.
No, that's very clear, David. That's a good way to put it.
Barry's got his hand up.
Yeah, thank you for that, Rawiri. That's one of the questions I have is that you're talking about the money. Who and how do the priorities get worked out? I mean, clearly you've got a small bucket of money, and the other group's got all the money, if you like. Something that's very important to you. How do you work out? You know, it's important to you, but it may not be important to the other agency, but you want things done. So how does that prioritization, if you like, or the resourcing get tackled?
So a couple of things, I guess. I'd notice the interim New Zealand health plan, paitata, and that's a negotiated space, right? And at a certain level, it's got to start with some of the major players, and actually we've got a New Zealand health plan which both boards have signed up to, and so there's been a degree of involvement and partnership and relationship that has happened at that level. Below that, you can imagine there's been teams, I don't know, geez, actually I'm pretty sure there's quite a lot of people on the webinar today who have been involved somewhat in the work that went into, you know, really rapid work, really intense amount of work, and a contested space. And so the boards have agreed a couple of things, and one of them was the focus areas, so cancer, mental health, kahu taurima, first 4 years, and long-term conditions. And so that kind of should guide us towards some of the programs of action that we need to be involved in. And then that contest that we're talking about will come down into the next level. Imagine any one of those. It might be long-term conditions. Let's now start describing what it is that's currently underway, and let's recommission that. That's a phrase I'm going to use as much as I can, because there's funding in our system and it's not delivering equity. So one of the tools that I've got in my toolkit is a spanner. This is how you use a spanner, Barry. You grab the spanner and you jam it in the system. and it just brings the machinery to a halt. So I'm not afraid to use the spanner. Here's another tool I've got in my toolkit. It's a hammer. And this is how you use a hammer. You just knock and knock and knock until you beat that thing into shape. So not afraid to use a hammer. And I've got one, I probably should have more tools in my toolkit, but you know, I've only got 3. So I've got a spanner, you know how to use a spanner. I've got a hammer, you know how to use a hammer. I've got a screwdriver. Now imagine a screwdriver is a very, very clever device. It can dial things up a bit and dial things down a bit. So in all of that, as we go through addressing programs of work and commissioning, and commissioning is going to have some really high level things at it, sort of national, but it's also going to be something we're going to be doing partnership commissioning or co-commissioning down here at a locality, and everything in between that, right? But ideally, there'll be some things where we get to go, actually, this is going okay. We just need the screwdriver to dial this bit up a bit, and we'll dial this bit down a bit, and let's keep going. And there'll be other bits where we actually, our conversations will feel more like Te Aka Whai Ora's pulled out the spanner. What are we going to do? Are we going to let this whole machinery come to a halt? Ouch. So, you know, yeah. Sorry, I've sort of, hopefully, I've given you a taste of where I think this is going to go. You know, so yes, some of this has already started, and there's a lot more to do, and there's enormous pressure to get this stuff done. I think I've got constituency that's saying, come on, you guys have existed now for months and months. What have you got done? What have you solved? Nothing. And so we've got to have some programs of action which we can go, right, let's lift this up and have a look at this. This is something we're doing which is new, it wasn't done before. Here's something we've stopped happening because Te Aka Whai Ora is here. We're not going to do something like this anymore. So we're recommissioning this funding because the new player is really not happy with the old way of doing things. And if we don't do some of those things, I think we've got a constituency who will literally say, you fucking got nothing done. Yeah. And it doesn't take long to get to that place. You know, your honeymoon, that partnership, that marriage, the honeymoon, how long's the honeymoon? You know, your honeymoon's over, Barry.
Thank you, Rawiri. It's very, very colourful idioms there, the spanner and the screwdriver. Is it starting to happen? Is Te Aka Whai Ora talking to Health New Zealand and the ministry? Is it starting to, are you starting to look at what is actually has been commissioned and how? Have you started to do that?
Yeah. So, and I'm loving my job. I don't know if you can tell, but I'm loving it, right? This is, it's not everything that I wanted. It's, you know, as a claimant in the treaty process, you know, I wish that we'd got a different tribunal report that was bigger and deeper and wider. It would have taken a long time. But anyway, we got stuck with this report that said, let's have a look at primary care and primary care providers and PHOs. And so it is what it is. And we've got a government reform agenda which establishes Te Aka Whai Ora, and maybe it's not as independent as I'd hope, but whatever. I'm old and I'm all in. I'm absolutely all. I'm going to give this 100% of my enthusiasm. And so one of the joys I have is discovering that there were bureaucrats with buckets of money over there in the Ministry of Health, and they've transferred into Te Whatu Ora, and they're about to lose their control of this bucket of money. And it might be a small amount of money, it might be just $1 million, $2 million, which is, you know, when you look at the 21 billion we're trying to influence, it's a tiny amount. But actually, I suspect that every $1 million that we can influence can be used to influence for some really good outcomes for patients. And then if we do that well, we should, you know, in a meritocracy, we should get more and more permissions. So somebody will come along and say, oh, look, we've got this funding bucket and, you know, we need to get it out the door. And they'll say, here's these 5 things. And I will politely, in my best polite language, I'll go, no, 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 fuck no, this one's a yes. And so, you know, out of all of that funding, I'm trying to bend it every time we find, and not just me, you know, we've got a bunch of Māori clinicians and Māori health managers inside Te Aka Whai Ora, and every time we find an opportunity, also known as a bucket of money with $1 million in it, every time we find that, we want to go, right, let's figure out, are we using the spanner, the hammer, or the screwdriver? And not afraid to say no. Yeah. And so every time we get that opportunity to bend it towards equity, that's, I mean, that just makes my day. Every day I can go home and go, yep, we've influenced another $1 million here and 20 million here. That's a good day.
Earlier in your talk, you talked about tackling racism and increasing funding for PHOs. Are there any other key areas that you have a special interest in and that you're working on?
Yeah, I've got an interest.
I know you're interested in everything, but which ones in particular?
Well, there's some things that I think I'm not interested in, then I get dragged along to a meeting and I go, oh, fuck, that is interesting, isn't it? Which is, that's complex and challenging for my my diary, my calendar. So I had the pleasure of being on all three of the task forces, right? So we had the planned care task force, we've got the immunisation task force, we've got the workforce task force, and they're really, really different. Planned care was down and dirty, let's get a report, let's get busy, let's get started, and it doesn't have a long-term trajectory as an entity. Immunisation task force, slightly different complexities, and so it's got a trajectory, I would hope, of maybe a year, something like that, and then some of the work that it comes up with should transfer over. It should be a positive disruptor for what's a complex problem right now. Let's be honest, we've got a health system which has failed to deliver an action in the face of need. That's called racism. That's a definitional criteria for racism. So we've got a health system which is designed and delivered, under-delivered for Māori consistently, and our immunisation rate for measles has fallen to 61% for Māori kids. You know, this is a disaster waiting to happen. This is a critical moment for our health system. We're going to have to, I think we're going to have to get a megaphone here. Might need a new tool, but it's going to get loud, and we are literally facing the risk of Māori deaths, right? So really important one. And then the workforce task force has a much longer term trajectory, because you can't solve some of those problems real fast. You know, let's try and figure out things that we can do right now and get busy and do them, but let's also get busy on the things that are going to take a long time. And so those are really important things. But so the task forces are really, really different. Yeah, so I do get dragged into some things that I would have thought were not really my priority, but every time I unpack them and say, so how is racism working here? That should be in your fellows' tool set, right? Everybody's got a tool that's called How Does Racism Work Here tool. We've got to do, it's an analytical tool that's in your toolkit, all of you, right? How does racism work here? So when we're talking about, I don't know, there's a waiting list issue for kids for grommets or something like that. You know what? We've built a system in which the referral pathway is, if you have 6 episodes in 6 weeks, then you can refer to an ENT clinic for a first specialist appointment. Can you imagine how fucking hard it is to get seen 6 times in 6 weeks in parts of our health system? You know, so we've privileged people who can access 6 appointments in 6 months. Sorry, 6 appointments in 6 months. No, we screwed this up. We've fucked this up. That is not the right way. So we're going to have to unpack that one and figure it out and get the right people into the system and not have dumbass ways of doing things. And so, yeah, I'm interested in doing that. I'm interested in some of the other things that we could do less of so that we get a better result. And so COVID has been a massive teacher for us in a whole lot of things. I think we made some massive errors in our pandemic response. And one of them was having health professionals doing the vaccination. And so, you know, we've done a whole lot of work in South Auckland with our Mana Kids program and demonstrated in a scientifically robust way that taking a throat swab did not need a nurse. So we could train non-regulated health workers to do that. And so even though I'm sitting in clinic today, I don't do throat swabs. I've got you know, a whole lot of other staff who can be trained to do that, and I don't do them. And if you ever come to me with a kid with a sore throat and you need a swab, you don't want me doing it. I do 3 a year, and I've got staff who will do 30 a day. Can you figure out who's better at this? Right, they are, not me. And so, and we tried to do that in the pandemic and have non-regulated workers doing the nasopharyngeal swabs. And we had a program and we trained them, credentialed people to do it. But our system would always bend back towards having nurses do that. And that was a tragic waste. It took nurses off the front line of doing work that we needed them to actually be doing, and it was unnecessary. And then along comes the vaccine and we did the same fucking thing. Unbelievable. We had nurses doing the vaccines, and actually we had a workforce that was completely capable of being trained in delivering the vaccine, and all you need at any one site. You know, what a battle we had to be able to set up the vaccination centres. And, you know, originally we couldn't do drive-through, and originally we couldn't do, you know, mass vac centres, you know, because we had to have a special room to consent people. And so, you know, there's a whole lot of things that, you know, COVID learnings, it says, let's blow that bit up. There's probably a spanner required here, Peter.
Yeah,
and
well,
we stop that and go.
I also think there were a lot of good things, especially in the early days, about bringing the team of 5 million together and everybody getting on board to fight that pandemic. I want to change the topic now. I can remember working with you on when we reported statistics for Y2575, and I just want to get your thoughts again on a comparator group for Māori. So in our data analysis, readers, I work for the Ministry of Health and the Māori Health Director, and in our data analysis, when we present a comparator group for Māori, in the past, we've always used the non-Māori group, but starting from Y2575, when we worked with you on that, Rawiri, you introduced us to the non-Māori, non-Pacific group. What do you think that's which comparator group do you favour at the moment?
Yeah, it depends. Depends on the setting.
Because, you know, the idea being it's no good saying the rate's gone out if you can't compare it to anything.
Yeah. And so I'm just scroll through. Oh man, there's some big brains on this bloody webinar. I better be careful, eh? There's some big brains. Okay, and so the big brain are already answering the questions in their heads, because there will be times if you do something diabetes in South Auckland and you're looking at a rate and you do Māori, non-Māori, you're going to miss the disparity, because it will actually be, you actually have to also see we've got a racist health system which is not serving Pacific people. And so if we take that cohort and put it into the non-Māori, it will diminish the inequity. Okay, so to make the inequity visible, you have to be able to do the right analysis for any given problem. So lots of times it will be non-Māori, non-Pacific. There will sometimes be things where we'll go, no, we want to use Māori, non-Māori because, and we'll have a specific reason often about why we want to do that. So any good analysis will be informed by the intention, I think.
Have you done any work with the iwi Māori partnership boards and determining the areas? Do you know how that's going?
They haven't let me near that at all.
Oh.
I think it's interesting and it's complex, and I'll make some predictions. It'll be contested, right?
No doubt. They,
Yeah.
they probably didn't let you into it, Rawiri, because you got a spanner in your toolbox.
Yeah, that's right. He's got the wrong tools. Don't let him come near this. See, even Ngāti Hinerangi, where I'm sitting, we're now a post-settlement iwi, recognised, but we're not in the iwi Māori Partnership Board. So when my iwi has its annual general meeting in December, I'm saying to them, I think we've got to discuss that. And you can imagine that there will be lots of iwi who are going to go, hang on a minute, you didn't include us in that. Isn't that interesting? Look who's been organising the establishment, the iwi Māori Partnership Boards, but you didn't include us. So it'll be contested in that way. There will be contestations about geography, about where one thing finishes and where one ends. My wife and I were doing a road trip the other day. It was an electric road trip because we only drive electric. And anyway, we were thinking about the road signage as you go from one area to another, and that you're traveling into the in another geographic location where another iwi is the mana whenua for it. And some iwi will go, we want double vowels, and some will want macrons, and some will go, no, I don't want fucking macrons or double vowels, right? And so how do the road signs, if you were waka kotahi, how do you recognise that this contested area is, the mana whenua status is contested. And in 1830, this iwi was dominant in this area, but in 1840, this iwi was dominant in that area. And so, trying to imagine how you might do that, and we were thinking about, so as you drive towards an area, at some point you should have the road signs in Māori consistent with the orthographic convention of the iwi that you're driving towards. Or, if you turn around and drive back down the road from the other direction, you might have the same place names using another convention for macrons or double vowels or whatever, right? So sometimes we're going to have to think like that as we go through some of the complexity of iwi and rohe, and so we're going to, and if we don't do it flexibly, then I think we're more likely to get to a litigation space than if we do it flexibly. We've got to find a mana recognising technique or tool or process as we go through some of that. But anyway, I'd love to get involved in it. I think the iwi Māori partnership boards are going to be fascinating, and influential. I hope they are, and I've had nothing to do with it so far.
You're going to have to have a bigger toolbox, I think, Rawiri.
In our questions and answer, there is I think it's more of a comment rather than a question, but it says, it's from D. Sinclair, and it says, I agree with your frustration about vaccinations. Part of the discussion when independent vaccinator authorisation set up was to free capable people, especially for Māori health services, to do things like vaccination at the home and TKR or marae. Thank you for that comment, D. Sinclair. We were scheduled to finish in 10 minutes. Does anybody have any questions?
We should finish early. Come on. We've got antibiotics to prescribe here, people.
Rawiri, one question following up on your comment before, and David Sinclair has mentioned as well. Do you think a lot of that problem was that COVID response was so heavily driven from the centre rather than, the operational part that you were involved in particularly?
I mean, that's an observation, and I also acknowledge what Peter was saying too. I don't want to sound that it's complete tragedy and disaster. I think there's lots of elements where we can go, we did a really, really good job. But I'm agnostic as to whether or not the solution would be if only the centre had done this versus we had better ideas over here. Clearly, we had a lot of I think we had more things right. Yeah, no, it's such a hard question, Barry. You're asking me to, ooh, yeah, the centre certainly got some things wrong. We certainly got some things wrong in regional settings and sometimes in provider settings. Yeah, I think I'd be happy to share the blame pretty much across. You know, there's plenty of mistakes made, and there's plenty of good things done. Yeah, so I'm not going to characterise it as being a problem between the centre and the other parts. Yeah.
Okay. Well.
Okay. I think we might wrap it up now. David, do you want any further comment before I close it?
So I was at another meeting recently and somebody asked about how we do this partnership stuff, and I think my answer was along the lines of depending on the situation, reach out early. And so depending on the situation, what does early mean? So if it was something that's kind of legislation and regulatory, there's often a really long time frame. There's a big amount of time to build the relationship and stuff like that. And if it's an emergency, there's often very little time. But there's always time to reach out to involve Te Aka Whai Ora. Sometimes we'll get snippy and go, oh, for fuck's sake, you can't expect us to turn that around in one day. So somewhere in the middle where most things are going to be, they're not absolutely critical, urgent, must be done today. And the things that are really long term and can take years to build, most things are going to be somewhere in the middle there. But just encourage people to reach out earlier rather than late. And that gives us a much better opportunity to kind of build the relationship and get the right people involved in that relationship building stuff. So I imagine that's fucking brilliant advice that all of you have written down, and just reach out when you need it. There you go. Thanks, Peter.
Thank you once all for coming. I'll just close our meeting now. Tēnā koe Rawiri mā mihi ki a koe, ka tahi te kōrero mārama, te kōrero whakangākau. Kia tau, kia tātou katoa, te ata whai o tātou āriki o heu karaiti. O te aro, te atua me te whiwhinga tahitanga ki te wairua tapu, ake, āmene. Kia ora tātou.
Thank you, Rawiri. Excellent.